Navigating the Orbital Landscape, a step-by-step guide in understanding normal orbital landmarks on computer tomography imaging. Before CT, there was an examination called pneumoencephalography, in which a patient was strapped to the chair and air was injected into the spinal column and patient was turned upside down and sideways. Here, air would move up to the ventricles and X-ray was taken. Any difference in the size of the ventricle would be suggestive of a mass lesion. This procedure was very painful and would induce vomitings and headaches in patients. In 1971, CT began with the pioneering work of two talented individuals, Mr. Alan M. Cormack and Mr. Godfrey Hounsfield. This is the first CT image showing tumor in the brain. The X-ray tube of the CT machine emits beam of X-rays that are attenuated as they pass through the tissues and are detected by special detectors. Within these detectors, the X-ray photons generate electrical signals which are converted into 2D or 3D images. Earlier, CT scan acquired images sequentially, one single image at a time, which was very time consuming and patients were subjected to more exposure. In 1980 came the spiral CT, which acquired data in a continuous fashion. The X-ray tube rotates in one direction around the patient in a helical manner, while the table on which the patient is lying is moved only in one direction. This dramatically reduced the scanning time and exposure, but would take only one slice per area. In 2000 came the multi-slice CT, placing multiple rows of detectors per area, allowing simultaneous scanning of several slices and decreasing thickness at the same time, reducing exposure time and improving the quality of the image. The X-rays are attenuated according to the tissue density they pass through. More dense structures appeared white, while less dense appeared black. By convention, and according to the degree of attenuation, each tissue receives a specific Hounsfield unit. Water is given a neutral value of 0. Air is given a value of -1000, which appears jet black as seen in sinuses, and bone up has a Hounsfield unit of +1000 and appears white. Now here is a film of orbital imaging handed to you. What are your next thoughts in your mind and how do you interpret? Let me give you a brief checklist. First, see to the CT or MRI, which plane, tissue window, and normal structures. Now here we have a CT and an MRI. On CT, bone appears white, while on MRI it appears black. Imaging plane. The important landmark for imaging plane is the reed spaceline extending from the inferior orbital limb to external auditory meatus. The coronal scan passes perpendicular to that of reed spaceline, but are usually angled slightly oblique to avoid dental artifacts. Axial scan passes parallel to the reed spaceline, while sagittal passes medial to lateral. These are the coronal sections anterior to posterior. In anterior coronal, frontal sinus is appreciated better and this hyperdense lesion is lensed. Other anterior sections show globe, where extraocular muscles are not much appreciated. In mid-coronal, both globe and muscles are well appreciated. As we go posteriorly, there will be no visibility of the globe, while extraocular muscles and optic nerve are seen clearly. These are the axial section. In inferior axial, the nose is more prominent, while in mid-axial, the globe with lens, the extraocular muscles and the optic nerve is seen clearly. And as we go superiorly, the brain parenchyma becomes more prominent. These are the sagittal cuts from medial to lateral of the right and the left eye. And as we go laterally, we see that the sinuses are becoming less prominent. Tissue window, bone window or soft tissue window. On soft tissue window, the soft tissue is delineated very well. While on bone window, we can appreciate the cortex and the medulla of the bone. The common indications of orbital CT are unexplained proptosis, palpable orbital mass, intraocular tumor with proptosis, and orbital trauma. This is the bony orbital wall. It is a pyramid shaped and tapers towards the orbital apex and optic canal. It has 4 walls: the medial, lateral, floor, and the roof. The roof is made of frontal bone and lesser wing of sphenoid. The medial wall, frontal process of maxilla, lacrimal bone, orbital plate of ethmoid, and lesser wing of sphenoid. The lateral, frontal process of zygomatic bone and greater wing of sphenoid, and the floor, zygomatic bone, orbital surface of maxilla, and orbital process of palatine bone. Paranasal sinus. The orbital roof houses the frontal sinus superiorly and is seen well on anterior most coronal scans. The maxillary sinus lies inferiorly to the orbit and best seen on coronal scan, inferior axial and sagittal section. Medially lies the ethmoidal sinus as seen in coronal and axial scan. The sphenoid sinus lies posterior medial to the orbit and has a common wall with the optic canal as seen in coronal and axial view. Here is an overview of paranasal sinus. Medially lie the ethmoidal sinus, inferiorly the maxillary sinus, and posteriorly the sphenoid sinus. The other important landmark is the lamina patricium, which is the thinnest wall in the orbit, lies in the medial orbital wall, and it lines the ethmoidal air cells. These are the turbinates, inferior and the middle turbinate, and the important structures which opens into the inferior meatus is the nasolacrimal duct. Crista galli is a smooth triangular process arising from the ethmoid bone. It separates the olfactory bulb, which lie on the olfactory fossa formed by cribriform plate. Cribriform plate is a C-like structure between anterior cranial fossa and nasal cavity, through which pass the olfactory nerves. This level is very important in endoscopic surgeries and thyroid orbital wall decompression. Orbital apex is anatomically defined as a region between posterior ethmoid foramen anteriorly and openings of optic canal and superior orbital fissure posteriorly. Optic canal. It lies within the lesser wing of sphenoid, through which optic nerve and ophthalmic artery pass, and is seen in the upper axial scan. The optic canal lies medial to the anterior clinoid process, which appears to be opening into the sphenoid sinus as seen here. Enlargement of the optic canal is seen in tumors of the intracanalicular part of optic nerve, whereas it decreases in diameter in cases of fibrous dysplasia, Paget's disease, or hyperostosis secondary due to meningioma. Superior orbital fissure lies between the greater and lesser wing of sphenoid bone. It is the largest communication between the orbit and middle cranial fossa, and on mid-axial scan, it is seen to be communicating with cavernous sinus, through which pass the branches of third, fifth, and the sixth nerve and the superior ophthalmic vein. Enlargement of superior ophthalmic fissure may be seen in optic nerve meningioma with intracranial extension and carotid cavernous fistula. Inferior orbital fissure lies between the greater wing of sphenoid and maxilla, connecting the orbit to the pterygopalatine and infratemporal fossa, through which pass the branches of fifth nerve and inferior ophthalmic vein. Cellar and paracellar region. The important structures here are the optic chiasma, pituitary gland, and cavernous sinus. The cavernous sinus lies behind the orbital apex and is better visualized with contrast enhancement. On axial cuts, the lateral border of the normal cavernous sinus should be straight or laterally concave. Convexity of the lateral border indicates an enlarged sinus. Till now, we have seen the bony orbit and its important landmarks. Now let's discuss the soft tissue component of the eye consisting of the eyeball and extraocular muscles. This is the eyeball, the medial rectus, lateral rectus, levator palpebrae superioris and superior rectus complex, inferior rectus and superior oblique, and optic nerve. The two important orbital spaces are the extraconal space, which lies outside the muscles and the intermuscular septum, while the intrasconal space lies within the muscles and the intermuscular septum. The most important structure in the extraconal space is the lacrimal gland, which lies in its fossa superiotemporally as seen in the coronal and axial scans. Superior ophthalmic vein is an important vascular structure, and it is enlarged in cases where there is raised venous pressure, AV malformations, or vein thrombus. Another important intraconal structure is the optic nerve. The imaging plane inclined at 30 degrees to the reed's baseline scans the entire anterior visual pathway in a single image while the patient looks up. Now here I would like to draw your attention and highlight the checklist while interpreting an image. First, check for the patient details. See if it is a CT or MRI, which window, and the orientation if it's axial, coronal, or sagittal, and look for the normal and abnormal structures. Thank you.